I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. Our guest today is a good friend and a colleague, Dr. Ben Margolis. Welcome, Ben.
Thank you, Craig.
So, we talk on this program a lot about health and wellness for people with intellectual and developmental disabilities. Tell us what you do in this field, what type of clinician you are, and the role that you play in providing health care to people with IDD.
So I guess we could call it neurobehavioral care. So I provide behavioral health care for people with complex needs and intellectual disability. I do some general psychiatry and work with people with concomitant movement disorders, neurodegenerative disorders, post-TBI, and with neurologic complexity when they have behavioral health needs. So I'm working out of a community mental health clinic in Orange County, New York, so serving the Hudson Valley, and the catchment area is about 9 or 10 surrounding counties going up to like the Albany area and down toward Westchester and northern Manhattan for a couple of patients.
So I know you're board certified both in psychiatry and neurology, right?
Mm-hmm. Yeah.
Back when you were going through medical school, did you have much training about providing healthcare for people with IDD?
So no, and all of us either have early experiences and come into this with the intent and with experience in that way, or some of us kind of fall into it.
Yeah, I fell into it. So how did you come into it?
So I was blessed to be in a dual program. I did a combined residency in neurology and psychiatry at Brown after medical school. And my skill set really fit well into working with a behavioral neurologist. So I rotated my last year of residency. It was a 6-year program. It's an amazing opportunity if anybody out there is considering their training possibilities. The combined neurology and psychiatry route, I can't recommend enough. There are lots of wonderful models that work. And I didn't really see that many patients with IDD. I saw TBI and stroke and was very comfortable and familiar with working with people with structural impairments and disabilities or genetic syndromes from a neurologic perspective. But when I rotated with a behavioral neurologist named Ken Rickler, who was an attending at Butler and had an academic appointment at Brown, I saw that these patients were being served well by him, but that on the whole, they were not necessarily being served well. And that the standard of care for the individuals, even though Rhode Island was a standard setting state historically, was still fragmented and was still problematic. And it put a chip on my shoulder, as some of our colleagues say. And he had been looking to retire for about 20 years. And I realized I can do this, and I couldn't understand why other people weren't. And later I learned about some of the barriers to care, which, made that chip into kind of a boulder. Once you start working with the individuals and working with the families and working with the caregivers, you start to feel like you can't do anything else. And as hard as it is, you just have to keep at it.
I can echo that. It's one of these things, once you start working in this field, you realize, like so many fields, one field is not necessarily for everyone, but you learn very quickly, like, okay, well, this is not the field I want to work in, or you learn that this is where I need to be working for the rest of my career. And it sounds like you had that kind of experience.
Yeah, he had been looking to retire. He was caring for between 500 and 600 patients in a private practice model, and providing care through Butler Hospital. And I agreed to take over the practice, which was an absolutely wonderful experience, and trained under him comprehensively. Learned about the group of patients and was able to care for them for a little over a year before some financial realities set in about doing this kind of work under a private practice model. And the number of additional jobs and moonlighting I had to do to be able to continue to provide that care was unfortunately unsustainable. As many of the people who try and do this learn after a short amount of time. So actually, a brilliant nurse practitioner stepped up, who's actually here at our meeting, and took on that patient panel and is leading the way as a nurse practitioner. And I feel like the NP Army that is leading the way and accepting the care of patients that are the word ignored is the wrong word, but I would say just underserved. We'll go with that are underserved by allopathic and osteopathic docs is just a blessing. So he took over that panel, and I moved to New York, where I was recruited by an agency in the Hudson Valley, and so I'm now in a position where it's supported and funded, and very luckily there's not the power to I should say pressure to produce that comes with a private practice.
That's certainly understandable, and that is one of the challenges in providing healthcare to anyone who maybe requires extra time or has an extra level of complexity. And many times the payment system doesn't support the extra time that might be needed, or the extra complexity in the decision making, especially with payment such as Medicaid. Which it can be nearly impossible, really, to sustain a practice relying just on those on that payment source, which is one of the challenges. And I know it may sound like a bunch of doctors who clinically or classically you hear about, oh, doctors make so much money and blah 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 and all this kind of stuff. But there's a lot of expenses that go into providing healthcare for people, and if you're only getting a few dollars for a visit, you can't even pay your staff. So not all doctors make tons of money. I will tell you that for sure. So when we're talking about, let me switch gears here. You mentioned at the meeting. You said someone who's here at the meeting, and I want to make sure the audience knows that we're coming to you from the American Academy of Developmental Medicine and Dentistry annual meeting. This one happens to be in Denver, Colorado.
2023.
Yeah, 2023. And that organization, we've talked about it here in the program before, but it's a phenomenal organization that's really built by a group of clinicians, physicians and dentists and others who really have a passion for providing healthcare for people with intellectual and developmental disabilities, but also improving and growing the clinical competency of every clinician. So working very hard to provide training and to implement training into schools and organizations and so on and so forth. So tell us about that a little bit and the role that you play with AADMD.
So I joined AADMD early in my career. All of us who do this, who aren't connected to other providers doing the same thing, I think struggle with feeling disconnected because of problems of fragmentation of care, and there are a lot of us trying, and a lot of us who are not aware of how common our struggles and just our day-to-day lives are.
And speaking to that, I remember when I first found the organization, I had been practicing in this field for about probably 10 years almost by that point, and felt very isolated. Felt like, I was practicing in a field of medicine that I really wasn't trained for. I learned a lot of things the hard way and didn't really recognize that there were other people in the same situation. And when I found out about AADMD and came to the first meeting, I was like, wow, there are other people that are experiencing some of the same challenges, but also are getting to experience some of the same blessings that we have in this field and in providing healthcare to people with IDD.
Right.
Yeah.
I don't want to sound negative. When I'm talking about the challenges and struggles, it's the fact that It's the fact that when we're coming up against some of the barriers to care, and we're doing it on our own, not necessarily aware of the other clinicians, like you said.
Yeah, and other resources and people to talk to, bounce ideas off of.
It can be there's a potential for being disheartened or being burned out. I'm board certified in neurology and psychiatry.
Mm-hmm.
I'm not practicing general neurology right now. I'm doing neuropsychiatry, neurobehavioral care, like I said, but I'm part of the American Academy of Neurology. And Seth Keller, one of our past presidents, and a wonderful and active member of AADMD, founded a work group through AAN, an interest group, the Adult IDD interest group. And so I saw this announced and immediately joined and reached out to Seth, called him on the phone and said, how did I not know that you were here and that you were doing this and that there's other neurologists doing this? I was practicing more general neurology at the time. And he said, yeah, come to an AADMD meeting, check it out, and meet all of my friends. And I have, and it is absolutely, life-changing. That's not hyperbole.
I can promise you that's not hyperbole because I experienced the same thing for me. The people in this group, in this organization, have become some of my best friends. You certainly are included in that. Love hanging out with you, bro. But and it's just the level of passion and compassion amongst a group of clinicians working together for the common good or to improve health equity for people with intellectual and developmental disabilities is quite exciting and quite empowering.
Yeah. So if I could sell it a little bit back, I don't
Please do.
sell it. That's the wrong word to say. It's just so wonderfully inspiring. So AADMD is a group of family medicine physicians, ER docs, medical anthropologists, neurologists, neurodevelopmental pediatricians, psychologists, internists, med peds docs, at least one neuropsychiatrist, neurologist, and psychiatrist, and OTPT.
We did say dentist, right?
Nurse, and oral healthcare providers.
Yeah.
So a wonderful contingent of special care dentists, and oral medicine specialists. So we are a conglomerate, all of us doing our part, and contributing to whole life care and medical and healthcare and dental and oral healthcare for individuals with IDD. And because the struggles that we all have are systemic, when we come together, we share not only pain points, but we share solutions. And it's also a very unique organization in that included in leadership are students and residents.
That's right.
So that is among the most inspiring things, is that not only do we get the chance to help solve the problems that we come into, that we all discovered independently, trying to figure out how to do this on our own. We come up with shared solutions, and then we get to collaborate with future leaders and
and we also collaborate with people with intellectual and developmental disabilities. We have board members who are self-advocates as well too, and participate heavily in our meetings. It's the nothing about us without us thing, and we certainly include them and listen to them, and they're a part of what we do in this organization as well too.
Absolutely. Yeah. So one of the things that we share is that people with intellectual and developmental disabilities and disabilities on the whole are not afforded the respect to which they are entitled. And one of the things that I think we share along with them is that in dedicating our lives to the care of these individuals, not only do we see the lack of respect afforded to them, but we experience that together. Yep. Along with them. And one of the things that I have found in AADMD is the joy and comfort in mutual respect and in problem solving, and that undercurrent of respect the whole way through, including the individuals themselves that we and the caregivers and the DSPs and the care community on the whole, is that's the life-changing part, and that's what makes this such a joy every year to come to share time with the kindest, really, and I say this and it's not hyperbole, the kindest people I have come in contact with in my life. So it is it's an honor and it's a privilege. And so a couple of years after I joined, I have been able to become part of the team in moving forward. So our prior treasurer was winding down her career to focus on other things. And so Alan Wong said, "You're a nice guy.
You're a guy we can strong handle into doing this."
Sorry, Alan. I kid. So, but he invited me to join the board and contribute as treasurer. So given what I learned in administratively in the small practice I had, and given the guidance of some family members who work in finance, I've been able to contribute and be part of the growth of the organization. And so we've got a lot of work to do in the coming year together in supporting the growth of the AAD.
Well, I sit on the finance committee with you, and you do a fantastic job at it. It's a blessing, and that you have taken on that role. So
it's an honor.
Yeah. So, well, it sounds like you kind of like AADMD a little bit.
Well, I could only invite other clinicians to come and see why.
And that's actually where I was headed with this is, clinicians, if you're listening out there, this is a fantastic organization for you to at least learn more about, if not join and consider joining, especially if you work in this field. But even if you don't work in this field, you are certainly seeing people with intellectual and developmental disabilities. And this is a phenomenal organization to be a resource for you, for information and advocacy and training opportunities and so much more. So I really, encourage clinicians out there to consider, just at least learning more about AADMD. And I think, it's pretty clear that it's a great field to work in as well, at any level, direct support professionals, nurses, physicians. It is an opportunity to really be of service to others, and can be very fulfilling and very rewarding. At least that's what I would say. I'm not putting words in your mouth, but I think you would probably agree.
Yeah, I mean, once you get started, it's not an easy job. It is absolutely not an easy job, and it can be easier, and we're in the process of making it easier.
Yep.
And the things that make it hard, some of them will not go away, and those are the things that we're here to support each other with, and to educate and teach and continue to manage. And some of those difficulties are the problems themselves, and some of the clinical challenges that are what we dedicate ourselves to, and that challenge is not necessarily going to go away. But the rest of it, we're in the process of as a team making it easier.
So Ben, one of the things I like to do is what I call 3 and 3. So I like to ask guests to tell listeners, viewers, anything you'd really like that you think could improve health and wellness, health equity, the lives of touch the lives of people with intellectual and developmental disabilities in a positive way. It can be, tips and tricks. It can be things you've learned along the way, words of wisdom that can again, just improve health equity. So go for it.
Okay. I don't know if there's three. Three is going to be tough. So I'll start with one.
One.
And then we'll see if we can come up with some of the other two. But
there's no penalty if
it's only one.
Yes.
Okay. So fundamentally, I think the core, because we already come from a place of respect. That is fundamental, and I think that as a field, clinicians have a tremendous wellspring of respect to offer. That I don't think is the issue, but I think the most valuable tool that we can use on the whole is communication. So when we hear each other, that's what makes the job easier. So when I think about the pain points from start to finish, people come to me for challenging or problematic behaviors. Behaviors are very, very often a means of communication. And it's my job as a clinician, as a neuropsychiatrist, to understand what that behavior is communicating. Sometimes it has to do with a fundamental neurologic issue, and then I can put on a neurologist hat. Sometimes it's communicating pain or a different kind of medical distress. Sometimes it's encephalopathy. Sometimes it's neurodegenerative issues. Sometimes it's communicating a different kind of pain or a different kind of distress. And when we are communicating and listening, and when an individual is heard, I can provide care. But on the other hand, there are all sorts of other facets or other aspects of that communication that are so fundamental, and that's the kind of infrastructure that AADMD can help build, and some of the training and some of the cultural competency that comes from us understanding how to get that information and how to educate teams of care providers and families to communicate with us so we can listen, and being able to communicate back so that we're not shouting into the wind, as it were, so that we can clearly make sure that we communicate and that we are heard with some of our recommendations, because communication is so fraught and so challenging, that looking at this as a fundamental cultural competency of being able to interface with the disability community, with the intellectual disability community, that is, I think, one of the fundamental tools that the Niche Project, which is the medical and dental curriculum that is a system of evaluating and implementing IDD care into medical and dental education. That's the core skill that will come from niche and niche dental and niche medical, and I think that will make our jobs possible once once communication is really established.
Sure.
A huge amount of my work when I'm meeting a patient for the first time and ongoing is just establishing and reinforcing communication so that we can do our jobs and do the nuts and bolts, stuff that is challenging, but often much easier because we're prepared for that in our regular training.
So it's communication, and communication.
Exactly.
And I echo that completely. Yeah. That's the way we share information. That's the way we interact with people. And just because somebody doesn't use words to communicate, they certainly still communicate. And it's on us as clinicians to understand that language that may be different. That particular behavior may actually be communicating something very significant and something that is treatable, that can reduce unnecessary suffering or pain or prevent a death in a person. So yes, communication.
Yeah, and one of the other things I also want to emphasize is that is that a big part of my communication is that while I do work in a collaborative fashion, as we all have to, and I do work with families, individuals, other specialists, primary care docs, the nurses, the behavioral clinicians, sometimes what a behavior is communicating is a DSM diagnosis,
Psychiatric diagnosis. Sometimes it is.
and so that's really important for me to be able to communicate. Is that there is value in using the tools we have available to help an individual live without being burdened by compulsions, obsessions, problematic self-injurious or repetitive behaviors, anxiety, depression, some of the things that can accompany developmental disabilities. And we are dedicated in this field to judicious, appropriate, cautious, careful, and appropriate use of these medicines to be able to facilitate somebody's best life. And so part of that communication is ensuring that a team trusts that I have the same interest at heart that they do as care providers, and that I'm on the individual side when I'm caring for them when they're my patient.
Well, it's clear the passion that you have for your patients, for this field, for the AADMD organization, the compassion that you have. That's one of the things I love about knowing you as a person, is you are an extremely compassionate person, and just one of the most humble people I know. I mean, you're one of the smartest people I know, and you're so unbelievably humble. And that's very endearing.
Very typical of this milieu. You know, this is not. There's the expression. It's not an expression. It's just true. Here, it takes one to know one.
Yeah.
And I can only encourage if people are out there listening, working in a silo, someone happens to hear one of your podcasts and says, "Hey, wait a minute, I'm doing that too." I am
Reach out.
atypical. I am not atypical of this organization. I am a part of and representative. If I'm giving that impression, and if your words are true, then come and see.
Well, Ben, thank you so much for taking the time to share your insights with us today. Thank you, though, more for the work that you do in this field.
Well, how could we do anything else, right? Yeah.